Also, real quick plug, don't forget to get your IEPRS T-shirt. I'll put the link in the chat real quick. The proceeds from this will go to support student scholarships for student involvement in the Institute. So I'll share that out a couple times throughout the day as well. Now we'll go ahead and transition to our introduction for our next speaker.
Good morning, everyone. My name is Travis Smith, and I have the pleasure of serving as the moderator for our next session. I'm a second-year student in the DPT program at the University of Central Florida. My research and clinical interests are in the area of pain science and the impact of psychosocial factors on the pain experience. I have a few housekeeping items to mention. I would like to remind everyone that our lunch hour will be sponsored by Delsis and will utilize a separate Zoom link, which will be provided in the chat after the 11:15 a.m. lecture. We are hosting a raffle at 12:40 p.m. and please remember to join our networking social at 4 p.m. If you are on social media, we would love it if you would tweet or post along. Please use the hashtag IEPRS21. Finally, the last 15 minutes of every lecture will be reserved for Q&A. Feel free to ask your questions in the chat and we will try to address them. Before I introduce our next speaker, I want to thank all of our sponsors. Our next session has been sponsored by B Physical Therapy in Oviedo, Florida. At B Physical Therapy, Dr. Stephen Baylog, DPT, draws on his own personal experience as a patient to provide highly individualized personal care. At B Physical Therapy, you're guaranteed to experience personal attention, 1 patient per hour, quicker relief from pain, all treatments delivered exclusively by doctors of physical therapy, and treatment plans customized to fit each individual patient. Come to B Physical Therapy and they'll help you eliminate your pain, enjoy your life, and be your best. All of us at UCF would like to thank B Physical Therapy for their support. It is now my honor to introduce our next speaker, Dr. Adriaan Louw. Dr. Louw earned his bachelor's degree, master's degree, and Ph.D. in physiotherapy from the Stellenbosch University in Cape Town, South Africa. He is an adjunct faculty member at St. Ambrose University and the University of Nevada in Las Vegas, teaching pain science. Dr. Louw has taught postgraduate spinal manual therapy and pain science classes around the world for 25 years and has presented at numerous national and international manual therapy, pain science, and medical conferences. He has authored and co-authored more than 80 peer-reviewed articles, books, and book chapters related to spinal disorders and pain science. Dr. Louw is the director of the Therapeutic Neuroscience Research Group, an independent collaborative initiative studying pain neuroscience. He is senior faculty, pain science director, and vice president of faculty experience for Evidence in Motion. We want to thank Dr. Louw for joining us. Dr. Louw, the mic is yours.
Good morning. I hope everybody can hear me. Can I get thumbs up? Everybody got me? Awesome. I'm going to share my presentation with you this morning. And again, thank you so much for having me this morning. I'm really excited to be here. And, you know, I'm not sure if a Friday morning topic on teaching people about pain is the best thing to start, but it's obviously something that's near and dear to my heart. So today I want to talk to you about teaching people about pain. First of all, a couple of disclaimers this morning. I do write books on pain. I'm not here to sell them, just to promote and show the research we're doing. I'm also co-own a seminar company. I'm not here to teach you or to ask you to code those per se. Research is self-funded, and as I always jokingly say, I did recently at a pain conference get a cup of coffee from Pfizer. And so I have nothing else to declare. I'm just here to teach, and I'm having a little bit of fun time teaching you some of the work we've been doing. As I'm sitting here this morning, we are in March of 2020, and I wanted to tell you that there is an explosion in our knowledge of pain and how pain works. If you go to PubMed, for example, you type in pain or anything related to pain, there is a rapid increase in our knowledge and understanding and research published in this area. In the last 20 to 25 years, we've learned more about pain than ever in the history of mankind. And nowadays, it's not uncommon for therapists and doctors and nurses and PAs and trainers and chiropractors to talk about things like inhibition, facilitation, central sensitizations, peripheral sensitization, ion channel expression, glial cells. This is becoming part of our normal vernacular. On the flip side, we are sitting in the middle of a major epidemic. I know it's not lost on everybody this morning that we're in the middle of a pandemic with the COVID-19 virus, but prior to COVID, we have been dealing with this incredible pain epidemic in the world. And by the way, the pain epidemic is global. It's not an American thing. What is American, unfortunately, is the opioid epidemic that has resulted of that. We're dealing with massive scale. The CDC is telling us about 130 Americans are dying daily because of opioid use, directly translated to that. What's interesting, though, unfortunately, COVID has taken all of these problems and accelerated it. COVID, in many ways, is an accelerant. It has accelerated. People that are struggling with pain are struggling more with pain. People that are obese are struggling more. People that are unfit, not healthy, struggle more. So everything we've seen is accelerated, which means we're definitely going to be dealing with a major, what we call a post-COVID tsunami when it comes to pain. So what is today's presentation about? It's literally taking this incredible great news about how pain works and our understanding to our patients, to our clients. This is truly what our team has been focusing on for the last 20, 25 years in research. I thought it'd be good to start with the patient. It's always good to start with the patient, by the way, because it's all about them. It's not about us and our titles and our names. Imagine this, and by the way, this is a real patient of mine. I'm not going to name her. We're going to call her Susie today. I apologize if your name is Susie. This isn't a real name, obviously, but she's a real person. I need you to understand that. We often dehumanize patients often, but this is a real person. I can tell you her name, the name of her husband, her kids, etc., that came to see us. This patient comes into outpatient physical therapy, and she's got chronic low back pain, pain that's been there for years. In her case, by the way, it's been there for at least 3 years. Her pain is spreading. The pain started in her low back, started spreading to her buttocks, down her legs. So this in itself is now spreading from the original area. Non-responsive. She's been everywhere, by the way. She's seen therapists, chiropractor, the podiatrist. She's seen the pain doc. She's seen the surgeon. She's seen everybody. By the way, treatment works for a little while, but then really stops working. She's seen everybody. I mean, she can probably make us a list of 7 chiropractors, 9 PTs, 8 this, 3 that. And there's a story here, which I hope all clinicians can sit and resonate with them going, you know what, I hear that and I see that quite often. We know this happens, right? Fair enough. Then patient's pain is spreading, as I said before. We know this is definitely spreading. It's not getting any better. And ultimately, in this case, by the way, her pain is increasing. So if the pain is spreading, this is becoming widespread overall, her pain is also getting worse. This is the actual patient, by the way, and this is her standing in neutral on the left-hand side. And as a therapist, we would just ask her, can you move? And she bends forward. You'll notice she barely bends forward and she stops. Why did she stop? Well, it hurts. If I could put a stethoscope on her brain and listen to her brain, I'm very sure her brain would equate movement to pain. And this is a major problem. The minute our patients tie movement to pain, then movement-based professions like physical therapy, chiropractic, athletic training, all of these movement-based occupational therapy, all these practices are going to struggle because our patient is tied movement to pain. Conversely, she probably thinks if I stop moving, I'll stop hurting. And we know that's not true. Movement is probably the biggest painkiller on planet Earth. The problem is just she's afraid to move. In this case, we have a major problem to get her to move. We know movement will work. We know movement is very, very beneficial. The evidence strongly supports that. But we have a problem. And in this scenario, I know my psychology friends, even my occupational therapy friends are laughing right now, going, well, duh, right? She has a cognitive problem. And in most of the movement-based professions, mine included physical therapy, we haven't spent a lot of time thinking that, wow, what people think and believe drive their pain. What people think and believe drive their movement, which is what we're trying to improve. This then brings us to this idea, what do patients want from us? The good news is it's been studied. There's been a multitude of these studies out there, qualitative studies. When people come to outpatient therapy, we ask them, what do you want from us? And you have a beautiful list there. They want a diagnosis. They want education about their problem. Personalized care. My pain is different than your pain. Prognosis. How long will this take? They want to have an explanation. What's my plan of care? They want relief of their pain, and they want to be physically examined. Now, you'll notice I highlighted a few areas there, and a critical thing that people want from us is education. They want to be educated. The bad news today in our medical environment is that the current education we're doing is actually not only very limited, not helpful, it actually makes people worse. In this scenario, we use biomedical education. We hear things like, you got the back of a 90-year-old. Your back is full of arthritis. Your core is weak. You have a slipped disc. You have the worst back I've ever seen. And this list goes on and on and on. And most clinicians here can sit and nod their head and go, yep, I've heard those. What we now know is this increases fear. And fear drives pain very powerfully. By the way, it induces stress, anxiety, all of those, including catastrophization. So we must change the way we educate our patients. The real problem, however, is even more deeper than that, than just the words we use every day. It's the way we look at pain. I'm going to show you 3 slides now. These are probably my favorite slides of all the ones I teach. In 1990, Professor Helderman in Spine Journal came up with this concept and published it, and was so cool. Look at this. The way you and I, as a healthcare provider, are trained is that pain and symptoms, or symptoms and pathology, I should say, are linear. A grade 1 ankle sprain hurts, a grade 2 hurts more, and a grade 3 hurts more. It's linear. If you are a manual therapist, you poke on somebody's back. You poke lightly, ow, a little harder, double ow, a little harder, triple ow. It's linear. By the way, if you're a medical provider, you can measure blood glucose levels. You can measure RA factor, and based on how much you got on your test, can tell you how sick somebody is or how much treatment they need. Theoretically, we then come in and do an intervention, and the pain goes away, or the symptoms go away. For example, in diabetics, we give them insulin and the curve switches. As a manual therapist, I manipulate your neck and you sit up and go, I'm good. That still works, but we're not here today because of that. We're here for them. There is a subset of people out there currently in the world. It's about 1 in 4 people in this world sit in this category, where they have significant pain and disability, but we cannot find anything wrong with them on our tests. X-ray looks good, MRI looks good, CAT scan looks good, nerve conduction test looks good, but they really hurt. We can probably think of diagnoses like fibromyalgia, complex regional pain syndrome, chronic fatigue syndrome, whiplash, associated disorder, back pain, just simple, good old mechanical back pain. But before you get too depressed on a Friday morning in this lecture, I also want you to notice there are other people in this world. And by the way, we should study these people. Do you know there are people out in society today that have significant tissue issues, but they don't hurt? How cool is that? There are people today walking amongst us with bulging discs, and I'm good. People with a torn rotator cuff, I'm good. People with a torn labrum, I'm good. How cool is that? By the way, we got names for these people. They're called Alaskan commercial fishermen. They're called demolition derby drivers. They're called rodeo cowboys, rodeo clowns. How cool is this? This dichotomy that your health of your tissues and pain are 2 different things. For too long, we've tied the health of your tissues to pain. Simply stated, if you got pain, you must have bad tissues. And if you got bad tissues, you must hurt. And that's absolutely false. The problem is patients come to us every day and they really hurt, but the scans look good because pain is way more complex. This then brings me to what we're doing right now in therapy. It's called pain neuroscience education. A few years ago, a couple of students challenged me in upstate New York and said, Adriaan, if you had to summarize all your work in 1 slide, what would it be? And I'm like, oh my gosh, I hope I have enough to fill a slide. But this is really the essence of it. I want you to look at this real quick. Every day in the United States, every single day, 177,000 people attend outpatient physical therapy for back pain. I want you to wrap your mind around that. Today, 177,000 people are attending outpatient therapy for back pain. That's about 45 to 50 million people a year. Everybody okay with that? When patients come to therapy with low back pain, we spend an enormous amount of time telling them about their back. This is a good back, and this is your back. This is your disc. This is a good disc, a bad disc. This is your SI joint, good SI joint, bad SI joint. We tell them these mechanical models. But the point is we tell them everything about their back, their disc, their facet, their SI joint, their core, their transverse abdominis, etc. But we teach them nothing about the thing that brought them into your clinic called pain. Louis Gifford, who you see here, was a very well-known therapist in the 1980s and came upon this idea of, wait a minute, people come to us with low back pain and we teach them about the back, but nothing about pain. People come to us with shoulder pain, we teach them about the rotator cuff, but nothing about pain. And he went on this incredible quest of figuring out how pain works. And luckily for me and you, brought it back and we learned about it. What is pain neuroscience education? Is to teach people more about pain, from a biological and physiological perspective, and then seeing if it actually works. And guess what? It actually works. So with the advent of evidence-based practice in 1996-ish, mid-1990s, we've now done an enormous amount of trials. And sitting in front of you today, 7 systematic reviews, meta-analyses have shown that if a patient comes to us in pain, and we teach him about pain, how pain works, and I'll show you how that works, their life is better for it. Their pain rating goes down. By the way, their catastrophization goes down. Their fear avoidance goes down. The disability goes down. They exercise, move more, even though they hurt. By the way, they even spend less on healthcare. We've now tested this and tested this ad nauseum on different patient groups. I want to put it in perspective. The 2 best drugs right now we're giving people on the planet for chronic pain is either a membrane stabilizer or a antidepressant. And so, for example, gabapentin. Gabapentin is used a lot. Gabapentin, right now, the numbers needed to treat. This is the number of people you got to give the drug to have one successful outcome is 6 to 1. The numbers needed to treat for antidepressants like your SSRIs, your selective serotonin reuptake inhibitors are 7 to 1. Pain neuroscience education for chronic low back pain, the NNT is 3 to 1. There's a slide missing here today, and that's the NNH, the numbers needed to harm. There's another slide missing called the NNK, the numbers needed to kill. And I'm not taking this lightly, but for example, the suicide rate after SSRIs are actually pretty high. And in this day and age, that we're looking at treatments that should be very effective, not dangerous, and can be used widely, P&E is truly standing the test. And I know I'm biased, I get it, this is the work we're doing. But as we're looking for ways to impact pain neuroscience education is emerging as a really good approach for people in pain. So how do we do it? We use pictures, metaphors, examples. During the history of mankind, how did we transfer knowledge from generation to generation? Well, it's through education. It's through storytelling. What we've learned is that you need to take the most advanced neuroscience in the world, put it in a story, tell a patient the story, and guess what? In a subset of them, their lives will be better for it. How do we do it? One-on-one. I sit with you across the table, or in group sessions, and more lately, we're getting into telehealth, virtual reality, applications, etc. So this idea of education at scale is definitely taking its course. During COVID, for example, this was a therapeutic strategy that could be used in these environments because we can do it via telehealth, etc. What you're seeing in front of you right now is really interesting. This is a summary my graphic designer made of some of the most complex issues that happens in a human being during a pain experience. We talk about nociception, peripheral neurogenic, how the nervous system is not only a passive conduit that sends information from point A to point B, but along the path, it can increase the sensitivity with things like ion channel expression, there's changes in myelin blood flow, etc. The dorsal horn, when we barrage the central nervous system, how there are plasticity changes within the dorsal horn with immune changes, glial cell activation, how the central nervous system can decide to ramp information up or calm it down. The brain undergoing these complex meetings, which you refer to as a pain neuromatrix. The list goes on and on and on. The point being simple, we've learned a lot about pain. The idea would be to take this to a patient, teach a patient about it where they go, I got it. And so how do we do it? Well, I'm going to show you how we do it, by the way. Before we do this, there is a poll, and I think the poll works. I'm going to trust the folks here at UCF to help me out. But I asked a simple little question, and I want you guys to take it from me real quick. Which of the following factors have been shown to be the biggest predictor of chronic pain? And you guys have to vote for me. It could be genetics, parental influence or upbringing, intensity and duration of acute pain, and fear avoidance. So I want everybody to vote real quick for us. I think we're going to give you guys a couple of seconds here and see how everybody votes and see how it goes. See if anybody can. And by the way, there is a correct answer that is very significant. All right, there's the answer. So with 70% of you believe that fear and fear avoidance is the biggest predictor of chronic pain. Coming in second is intensity and duration of acute pain. Third is parental and genetics. The correct answer is C. The intensity and duration of acute pain is the strongest predictor of pain, chronic pain we have ever measured on planet Earth. For those that have measured fear, you're correct. There's this classic statement by by Gordon Waddell, the fear of pain is worse than pain itself, Pain Journal 1993. These all, by the way, are important. So don't be down on yourself if you got it wrong. But we now know that the intensity and duration of acute pain, how we bombard the central nervous system, how long and how hard, actually changes plasticity, which sets us up for serious issues along the path. A good example would be, by the way, we've now shown with Colles fractures, if you fracture your wrist and you have a Colles fracture and your pain is only 5 out of 10, 5 out of 10 for 2 days straight, your chance of developing CRPS is 8 times higher than if your pain was below 5. Just to show you an example. All right, good answer. All right, so let me show you how we do it in a real patient. So in this case, we would use a metaphor. When a patient comes in, we will explain to them how pain works. Patient walks in, has anybody explained to you how pain works? No. Has anybody explained to you why you still hurt? No. Let me spend a few minutes and show you how pain works before we take you through some of your stretches and exercises. In this case, we talk about the nervous system. And we'll tell a patient like Susie, hey, Susie, our body has a living, breathing alarm system called the nervous system. Our nervous system works like an alarm system. There's our metaphor. When we step in a rusted nail, the nervous system working like an alarm ramps up, ding, 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 fires a message from your foot to your spinal cord, to your brain going ding, 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 ding. You produce pain to stop you, pay attention, and take the nail out of your foot. Does it make sense? And again, patients typically go, well, yeah, of course. Well, we now know in about 1 in 4 people, something trips the alarm system. Ding, 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 go get some help. And what should happen when you pull the nail out of your foot, the alarm system calms down. But in 1 in 4 people, when something trips the alarm system comes down and then decides to rest at an extra sensitive level. And we now know when this happens in people, it changes their life. So we're talking here about thresholds. Before pain, your alarm system gave you room to go run 5 miles, drive in the car to grandma's house, deal with stress at the office. But since you develop pain, your alarm system is now so sensitive, only a little bit of movement, ding, 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 the alarm goes off. A little bit of stress, ding, 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 the alarm goes off. Now, what you're looking at is a metaphor for central sensitization, peripheral sensitization, hyperalgesia, allodynia, etc. Now, I know you're watching this going, this is stupid. This is kind of silly, but it works. We have now tested on trials upon trials, massive randomized clinical trials. The picture I'm showing you right now with the one before this one and that one, is the highest ranked ones by patients in our trials. Simply stated, it's the ones that get people go, I got it. Thank you, Adriaan. You changed my life. Now, this sets us then up with the idea of how do we calm the system down? We then talk about all the therapeutic things we do, not to fix tissues, but to dampen the system. Aerobic exercise, meditation, sleep, nutrition, all the cool stuff that gives us a broader spectrum that moves away from fixing it, because nothing's broken. Your system is just sensitive. And by the way, what I'm telling you right now is exactly what we do on the medical side with membrane stabilizers, antidepressants, muscle relaxants anyway. How does P&E work? The nervous system, the brain that's in full-on mode of protection, basically starts producing happy chemicals, if you will. Your endogenous systems start turning on again, and the brain lowers the threat level, which translates to lower pain, etc. I'll quickly show you a single case scan study. This is a dancer. She has low back pain, L4, L5 radiculopathy, getting ready for spinal surgery. What you're seeing here is her laying in a scanner on her back, watching a simple little movie. Her life, very comfortable here, by the way. If you want to know which movie it was Finding Nemo. Our study showed there's no brain activity when you watch Finding Nemo. After about 5 minutes of Nemo, we ask her to move her back, to tilt her back, which is quite uncomfortable, by the way. And what you're looking here is the brain scan. And again, it's more complex. I get it. But what you're seeing is her brain is lighting up. When the brain uses more sugar, more glucose, these areas light up on the scanner and the brain gets busy. We call this a pain meeting, or the neuromatrix, if you will. After this scan, we pulled her out of the room, took her back to a private room and explained to her how pain works, sensitive alarm, etc. And then brought her back after this explanation, and you're seeing her doing the same task after 20 minutes of teaching her how pain works. Now, this translates, by the way, to a reduction in your pain catastrophization score, your fear avoidance score, straight leg raise goes up, flexion. And this is a single case design. I get it. Fair enough. But there's a body of evidence that shows when we teach people about pain, the brain calms and dampens the system down beautifully. Here is Susie again, and standing in neutral after therapy, teaching her how pain works, no physical treatments, asking her to move again. This is her inflection, this is her an extension. These are not Photoshop, this is a real patient, by the way, as I said, and this is actually the patient that changed my life. This is the one that made me go, whoa. As a manual therapist, to see how powerful people's thoughts, emotions, and beliefs drive pain, that drove me towards this pain side. And again, simple design, simple case study, I got it, but it's a real person that we see every day in real clinical practice. I want to finish off a couple more minutes of this, and then I think we're supposed to take some questions. There's a famous quote out there by the behavioral psychologist, Dr. Bill Fordyce: education to behavior changes like wet spaghetti to a brick. In the United States right now, we're spending $2.1 trillion, not billion, trillion dollars telling people smoking causes cancer. We cannot print it large enough in cigarette packages, and only 1 in 5 people go, okay, I should stop smoking. My point being, education by itself isn't the best behavioral treatment on the planet. If it was that simple, nobody should smoke. You need something else. You cannot just tell people how pain works. You need other things. It's what we're trying to get to. What you're seeing right now in front of you, there are 22 things that, and sorry again, I'm a physical therapist, this is the research we've been doing, but in physical therapy, for example, and I can easily put in my occupational therapy friends, chiropractors, athletic trainers, etc. There are 22 things we do on a daily basis in therapy that actually turns the brain's chemistry back on, turns on the happy chemicals. All of the things I'm listing here have shown that the brain can be turned on again. What you're seeing here is what we would refer to as the anti-opioid program. This is what we're teaching in big medical systems, the VA, the DOD, etc. You cannot taper opioids from a person unless there's something to take the gap. And as a therapist, a clinician, a non-pharmacological clinician builds the right-hand side of this equation, we can start tapering, which we now have shown successfully in some of our research. This then brings me to the current best evidence for treating chronic pain. What you're seeing right in front of you right now is unequivocal. We do not have to study this again. The best way to treat chronic pain is 3 things. We got to change how somebody thinks, we got to move them, and we got to calm the nervous system. On the cognitive side, you can pick your poison. It could be cognitive behavioral therapy, pain neuroscience education, acceptance, commitment therapy. It could be motivational interviewing, positive psychology, whatever your bent is or the area you're interested in. For movement, it could be anything, right? It could be traditional type of movement, aerobics, resistance, isometrics, endurance, etc. While non-traditional, we often talk about things like Pilates, yoga, Feldenkrais, Tai Chi, the list goes on. But we got to move a human being. Then we got to calm the nervous system down. There's 2 ways. One is pharmacological, which medical providers can help us with, but then also therapeutic, which is that 22 different things. As you look at this list, I need you to understand how powerful non-pharmacological treatments can be in treating chronic pain, especially chronic pain with opioids attached to it. Movement, a good example. We now know that a 6-mile run produces 10 milligrams of morphine in the brain. Think about it. If you broke your arm today and I took you to the emergency room, you'll get about 2 or 3 milligrams of morphine to set your wrist. You can get 3 times that by going on a 6-mile run. Now, I'm not telling you to go run with your arms broken. Don't go to the ER, go for a run. But my point is, we get studies upon studies upon studies to show that movement calms the system beautifully down. How much? And again, I apologize. This is probably the wrong audience to bring it up because you guys are the experts. I'm going to completely mess this up. But the intensity of exercise to turn the brain on is around 50% of your VO2 max for 10 minutes. You and I call it the runner's high. You put on your running shoes, go outside, you run a few minutes in. Oh my gosh, running is hard. I shouldn't run. I'm kind of sore and achy, but only to find a few minutes later, things are gelling and you're running and like, this feels good. I should run more. Maybe I should run a marathon because your brain starts producing these chemicals. Now, I know there's an equation between VO2 max heart rate, etc. But for me, in the chronic pain world that we're working in, it means for most of our patients that are relatively sedentary, if we can get their heart rate above 120 beats a minute, we are tapping into this model. And this is very powerful for me as a therapist. What does P&E have to do with this? Well, it's planting seeds. Watch this. I'm almost done, and we can move into some questions. And this is a great study published by Dr. Annelien Malvliet and the team in Belgium. I want you to look at those charts on education. They measured two scales here. One is pain, changes in pain vigilance and awareness. The other one is changing in pain disability. There were two groups of people with chronic low back pain. One group got pain neuroscience education, and the other group got education about their back. Notice in education, baseline and then post-education, no difference. Can you see P&E did nothing? P&E didn't make people better. But the minute we added exercise, which is put in that purple box there, people started splitting. What made people better? Movement. But what did P&E do? It primed them. P&E is a primer for movement. It reduces threat, fear, anxiety, which allows people to move. And what makes them better? Movement. So P&E itself, again, as a standalone, like all other education, isn't that powerful, but it gets you ready to move. And that is the cool part for rehab sciences. Biggest thing with movement, again, we don't blast through pain. We don't stay away from pain. We tease it, touch it, nudge it, graded exposure. We teach patients mantras via P&E. Hurt doesn't equal harm. You're sore but safe. As they nudge and nudge and nudge, the line shifts over time. Just remember, pain that is understood is not to be feared. I'm going to say it again. Pain that is understood is not to be feared. When people experience pain in rehab and they feel their knee, they feel their shoulder, but they know what it is, it's just sensitive. The nervous system is sensitive. My alarm is sensitive. They're not afraid of it, which means they will push further, which drives them for better recovery. There are four main things we got to make people better when it comes to chronic pain. Teach them about pain. They got to move more, sleep better, and they have to have goals. And then we start adding all these other components. I know that was a lot of stuff. Again, I want to thank the committee for having me this morning. I want to thank all the collaborators, people that work with me every day. I'm only here today because a lot of people have been kind to me and taught me over the years and given me an opportunity to do some really cool stuff. So I think at that point, I am done.
Thank you so much, Dr. Louw. That was a great talk.